I do agree with you because donor vessel ischemia is also a very bad complication while doing the long hours procedure. But I must acknowledge Jahal who taught me, first puncture. And I still remember my senior professor, who died from last corona, who taught me how to be relation. And may Allah bless Jannah.
Is there any morphological change in the flag, proximal or distal? It is easy to approach electrocuting. Is there any change in the flag?
Yes. In all algorithm, you should first try antigate, then if you can't do it, then you go retrograde if there's a good collaterals. And you can switch also. In some cases, you try retrograde, it fail, and then you can again come to antigate. So, morphologically, if there's a blunt stump, and if there's a long CTO, and then we usually go for retrograde, and if there's a first attempt fail.
Thank you, sir, for your nice question. I have done for the sake of time, I think this will be the last question for this topic. When we will move to the next. I have done a CTO case 3 days before, and I have faced a problem. What should I do and what I do? I want to know from you. I totally offended RCA. I went through a pilot 150 and with a contralateral LED dye. Then I reached more than 2/3 of the lesion. Then wire profile become lost. Then further I take a Confession Pro 9, and with the help of contralateral injection, I can overcome the lesion. And after going into the PLV, a dissection occurred, and patient BP become tall and bradycardia 34 developed. Then I give iron pro, oxygen, and then I go femoral root further. And I place a stent in dissection and proximal part, and patient become settled. What should did for me, my patient was stent placed in the dissected part, or wait sometime then dissection spontaneously healed, or postpone the procedure for improvement of the patient.
Thank you, Munir. Really, I look forward for all young intervention cardiologists who are doing such a wonderful and congratulations for taking this RCCC. What you have done, you have done the right thing, but my answer to the question, when there is a complication, first save life. Pressure falls, so you give another fluid. You put a TPN, there's a bradycardia, stabilize the patient. Then you have to restore the flow the RC. So if there is small sections not flow limiting, then you can treat only the main CTO and leave the dissection behind with some integrity. But if it is a very big dissection controlling the flow, then you have to send the whole length of the RCA, including the dissection as well. So first you save the patient by giving another fluid and then you tackle the lesion, which you have done.
Thank you.
Now we'll move to the next question. Topic is state of the art new global
to be cutting down the entire discussion. Please talk to us after the
And we will have question answer at the end of the session.
Yes.
So no question in between.
I was wondering whether there's any role in giving my talk for global algorithm, but I'll still ask to share these few slides, and I'll explain that to you in a little bit. What is the new global algorithm for Cto PCI, what, why, and how. So this is a state-of-the-art paper that came out in JAC recently about a global chronic total occlusion algorithm. And we have about 121 operators from 50 countries participated in this. When you look at a CTO PCI, what is success? How do you define? Just crossing the lesion with the guide wire in distal 2 lumen, or technical, that means the TME2 flow are greater and less than 30% diameter stenosis and distal branches more than 2.5 millimeters vessel, and or procedural success, which is no in-hospital MACE or death, MI or TBR. That is the most important. So in CTO crossing strategies, rather than thinking about how subintimal and true or false lumen, I think is a better way of looking at it. Only in segment before or after the CTO. So this is a new thing. You just don't start thinking that it is subintimal or is it a true lumen or false lumen, because we get back into the true lumen anyway. So in the what is the intention in CTO crossing? The intention is not the real position, but in the document strategies used in an order, where the successful strategy, what it was, later on you'll find out, and what is the strategy that might have caused a complication. So these are the ones that you think about, and which includes antegrade wiring, retrograde wiring, antegrade dissection re-entry, or retrograde dissection and re-entry. So there are only 4 broad ways of looking at it, right? And if you look at the JCTO score, the more techniques that you use are higher JCTO scores. So simple antegrade wire escalation is enough in a low JCTO scores, but the more retrograde or more ADRs you use in JCTO score high, the more complications that will happen. As I showed you in this slide, perforations that happen with the retrograde is 7.52%. So please remember that actually these should not be taken very lightly. So in America, we have a hybrid CTO crossing algorithm, which is the number 1 is the dual injection, thanks to Brilakis, Branson, and all of them who came out and wrote this paper in 2012. And based on the ambiguous cap of 4 distal targets and the appropriate interventional collaterals, you decide whether you go to retrograde or antegrade. If you have ambiguous proximal cap and any of those answers to 1, 2, 3 in step 2, you go for retrograde. And retrograde you can do, as I mentioned, dissection re-entry or true lumen. So these are, I'm sure you will be seeing these slides. So, but this is American algorithm, right? Then you have the Asia-Pacific algorithm from Japan, and Sujikane and others presented this. Asia-Pacific algorithm, which is slightly different. Then you have a Chinese CTO algorithm, which I did not show, but there is a Euro CTO algorithm. So everyone has their own algorithm. So what happened a few years ago was that let's converge all CTO operators. So invitation went up to 122 cardiologists who are CTO operators across the world, and asked them to come to a consensus statement, and at least a survey was sent. And 121 participated from 50 countries, and finally they felt that this is the best global algorithm. So this is a paper that has been published in JAC State of Art Review. So there are 10 steps for this. And dual injection is number 1, and careful analysis of angiogram is number 2. Proximal cap ambiguity is number 3, and if it is yes, you can go for presence of side branch and further steps like that. And 4, distal vessel quality, and antegrade wiring is number 6. It can be divided into partial wiring, parallel wiring with IVUS, or antegrade dissection and re-entry. And so number 7 is retrograde approach. 8 is actually changing the strategy. So don't get stuck to one thing. If you spend more than 5 minutes on antegrade, go to retrograde. If you spend more than 5 minutes retrograde, go to back to antegrade. And then if it is finally successful, it is not successful, it is an investment. But if it is not successful, you need to decide when to stop. So step number 10 also is very important. Consider stopping if it is more than 3 hours that you spend, 3 times the estimated GFR contrast use, or a karma more than 5 gray. So these are the 3 steps that will make you decide whether you should follow step 10 and bring the patient back on a future time. So these were the ones that actually very clearly said that about how you approach antegrade or retrograde, and changing the strategy is very important. And if you are not successful after that, think that this is an investment that you made. When did we start dual injection? It has been 22 years, and still when CTO is shown, people don't show dual injection. That is really wrong. I think this is the first step, and we need to really respect that and follow by David Holmes from Mayo Clinic has written down 22 years ago. So dual injection, how do you do it? Low magnification, 10-inch, inject the donor vessel, wait for like 2 seconds and then inject in the CTO vessel, and no panning. I always see that people love panning, don't pan. And cine until the contrast completely clears, or actually you can see it in the venous system. So it still remains critical for successful CTO operators. So the hybrid CTO algorithm, as I said, in number 2 is ambiguous cap, and if retrograde, if all of those are present. If it's not ambiguous cap and the distal targets are very good, antegrade is very good, is the step that you need to follow. So the most important in the global algorithm is studying the CTO is number 2nd step. But who should study? The entire cath lab team. How long? You should spend about 15 to 30 minutes and look at all the characteristics, at least 4 of them. So the 4 key elements are proximal cap, the lesion length, the distal vessel, and collateral. These are the 4 things that you're looking at in the global algorithm in step 2. So study with your team. It includes your nurses and technologists as well. So then you can look at JCTO score. The higher the score, the worse the prognosis is in a successful way, and you know that calcification, blunt stump, more than 45 degrees, and occlusion length, more than 20 millimeters, are the ones that actually will make it a worse prognosis for success. So there are other scoring systems which I will not go through, but so as a beginner, if you want to start CTOs, choose JCTO scores of 0 to 1. And as you're comfortable, and the next speakers will be showing, and if you're Omer Koktekin, the JCTO score of 5 is also okay. But that means you're be prepared for complications, and that's why he will show some complications. Yesterday, I think, and Sanjog was talking, and somebody asked about coronary CT angiogram versus angiography. The role is not in what he was talking about in these cases. It is mostly in CTO patients, where you can really make an impact on how the CT will appear. So here on angiography, it appears blunt, but on CT scan, it is tapered, so the success rate is better. Here, there is no calcification, but on CT scan, there is severe calcification. Looking at the angle, CT is much better at the angle than actually on a regular angiography. Occlusion length, what you think as 22 millimeters on an angiograph is only 10 millimeters, and so it can increase the success rate on CT. So CT definitely is much better than a regular angiogram. So crossing, if you have all these CT scores calculators and you reduce the JCTO score with the CT, the success rates are much higher, like in this patient, which took 2 minutes. Whereas in this patient, with the help of CT, you know that you're going to fail. So maybe not even attempting it is not a bad thing. So in the global algorithm, number 3 is the proximity cap. We talked about that. And if you want an ambiguous cap, you go for a retrograde, a retrograde crossing of just marker. Or if it is not ambiguous, then you go for antegrade, better angiography, CT angiogram, IVUS, I think Dr. Kalra will cover that. And moving the cap, which is a different types of way of doing that. So here is the RCA CTO, which is blunt stump. I don't think it's playing. So anti-grade wire escalation was done, and the CT co-registration and the IVUS in the marginal. As you can see in IVUS, if it is in the marginal, and you can guide where your true lumen is, and you can poke towards that with a stiffer wire. So if you're unable to cross, then switch to immediately to retrograde, and then with the Feeler XT and Caravel catheters, that this patient had a successful